can guarantee you'll have pages on pages about him and his works that he has done. He's here to talk to us about right to health. He's here to talk about right to health from an international perspective, which I believe will be something of interest for all the students that are here, including the faculty. And without taking much time, I would like to request the Dean of Royal School of Law to kindly do the felicitation for Professor Marks, sir. So that's a Gamusa of Royal Global University. And we also have a memento and a bag of Royal Global University. Thank you so much, sir.
Thank you.
There's many things, you can engage with him for some interesting discussions. Sir, it's over to you.
Thank you. I have a presentation here. Good morning, everybody. Good morning to you all. Shall I keep this on? I'm very proud to wear this. This is my second visit here. I came here for the signing of an MOU between our university and this university. It's always a pleasure for me to come back, and I'm looking out over the faces here, and I see bright young minds here. My talk today is supposed to be an opportunity for us to reflect on ways that you can acquire new understandings. And to do that, we need some interaction. So what I'm going to do is to ask you to be thinking in everything that I say. If there's anything that strikes you as saying, I don't quite get that, you're free to ask a question. Or if you say, that's not the way I learn things, maybe we can have a discussion about this. Please do that, because the idea is for you to be involved. Otherwise, I can make a boring, long talk, and then some of you can maybe try to get some sleep or something, I don't know. But so my purpose today, so I need to kind of divide this and break in between things. I'll show you the overall structure that I have in mind. Right to health and law and practice. This is a law school, so we will be utilizing a legal framework and legal concepts.
We also have all sciences.
We have some other which sciences?
All science.
Political science. Okay, political science. Very good. Very good. Because what is law if it's not politics, right? You don't get law unless you have the political structures creating the law. So I propose to discuss the concept in law and international relations and politics of the right to health in three dimensions. The first one is what I call the emergence and definition. Where did this come from? We have human rights, the right to be free, the right to vote. Where did health come in? That's not normally what you think of when you think of rights that you can litigate. But the right to health has emerged and has been defined. So that's the first thing. Where did it come from? How do we define it? And the second thing is, we have a core definition. Okay, there is a right to health. The Indian Constitution, the Supreme Court has interpreted Article 21 as saying there is a right to health. The United Nations has adopted a Universal Declaration of Human Rights and treaties that affirm a right to health. That's the core definition. You know that it's going to have something to do with how you receive treatment and care, access to treatment and care, improvement of your health conditions. You know that's what's going to be involved in it. But the second part of my presentation is about what I call new and derivative rights. What we call the normative expansion. Now, for you lawyers and political scientists, the concept of normative expansion is an interesting one. You start with something that is established, and you, for whatever reasons, and that's what we want to understand, it grows. It grows like an organism. From a small reference to right to an adequate standard of living, including healthcare. That's it, nothing else. What is it? Healthcare. So that's supposed to be part of a human right to an adequate standard of living, and that's all. From that tiny, minuscule little droplet, we've expanded into ways that I'm going to try to share with you today. And the third theme is the essential theme, and we have the lawyers and the political scientists. The political scientists can turn to the law students and say, you idiots, you think that just having it on paper means that people's lives change? We political scientists know better. We know that there are structures in society and processes that make things change, not because you write it down in a law. That doesn't bring about social change, the betterment of the human condition. It takes us political scientists to know the processes that bring about the type of change that improves the lives of human beings. I'm saying that deliberately to acknowledge the fact that we have law and political science students here. But the third theme is what I call from rhetoric to reality. The right to health, like all human rights, is rhetoric. It's something that you say. It sounds good. You like it. And then you put it down on paper. And you're really proud. Oh, we adopted this. We even worked on the language and we discussed it and debated it and then adopted it. What does that do to reality? It stays on paper. That's rhetoric. That's paper rights. How do you transform a right on paper, a rhetorical right, into reality that changes people's lives? And in human rights work, we call that the means and methods of realizing the right. Or, as we'll see when I get to that third part of my presentation, implementation of rights, realization of rights. So, are there any questions on the structure of what we're going to talk about? And what I'll try to do is to stop in between each one to make sure the concepts have been meaningful to you and you can ask questions. So prepare to ask questions and have a dialogue on each of these themes. Okay, any questions about where we're going? Does that make sense to you to structure it this way? With definitions, expansion, implementation. So let's start with the emergence of the right to health and its definition. Well, I guess maybe I should start by asking a student to tell us if you know the initial primary international document that defines the right to health. Do you know? You're not supposed to know, otherwise you wouldn't be attending this talk, but do you know? Where in international law and relations do you find a definition of the right to health? All right, that's good. Then that means I'm here for a purpose, right? Anybody else have some thoughts? What about you, sir? Do you know, where would you look to find the right to health as an internationally agreed upon legal definition? Do you know? Who said I didn't hear that. World Health Organization. Ah, but I thought you were lawyers. Is the World Health Organization a law-making body? Just a bunch of doctors hanging around with stethoscopes around their necks and trying to come up with vaccines and things like that. Well, you're quite right. When I initially tried to answer the question of where does the right to health emerge from and how is it defined, I published it in this chapter of a book called Advancing the Human Right to Health, which I co-edited with two colleagues. And so what I'm going to say for this part of the talk is based on that publication. And you're quite right. During the drafting of the Constitution of the World Health Organization, the conference that met included this definition. Maybe just to get things going, could you read it, please? What's the red arrow? What does it point to? Thank you very much. So you can see that these two paragraphs are the starting point that we're talking about. And the first one is not a statement of human rights. It's a statement challenging a different conceptualization of health. Not merely the absence of disease or infirmity. What does that suggest? Not merely, so they're saying, so don't limit yourself. Why are they saying that? What is that relevant to? Anybody have an idea? Can you? Why disease? I thought that's what health was all about. If you get a disease or you get injured, you need medical care. That's health. What else is it? Why say it's not merely the absence of disease or infirmity? Do you have any thoughts? Excellent. So that's a broader concept. It goes to the society we're in, the community that we're in. It's not just the physical well-being of an individual. And we're going to dwell a little bit on this distinction between what we call the biomedical model of health and the, what would you call the alternative? The one that you're referring to. The biomedical model would be absence of disease or infirmity. What would be the alternative that you're talking to? You have a... When you take in psychology, you take in society, mental health, and so on. Environmental health. These broader issues have a vocabulary that goes with it, and that's what I want you to take away today. There's a direct relationship between the scholarship of the 19th century dealing with the Industrial Revolution and the health problems that affected populations during pandemics and the impact of industrialization and poverty and so on. And some medically trained people, particular among them was Henry Sigrist, who published a book called, he was a medical historian, called Medicine and Human Welfare, Civilization and Disease. And this approach was called social medicine. In other words, coming from the medical field saying, we understand that it's not just our role as doctors to administer to a patient, the biomedical model. We know from understanding the social origins, the social determinants of health, that it's much broader than that. And a beginning must be made. This is in 1944, Second World War. The international system is emerging from the disaster of World War II, creating institutions to try to build a better world. And in 1944, he said, the beginning must be made and must be made soon, because in war, as in peace, people's health is one of the nation's most valuable assets. I'm convinced that medicine, like education, will ultimately become a public service in every civilized society. So this is one example of an author who's identified with this movement back in the early part of the 20th century called social medicine. And it's emerged, it continues to be a field. There are departments of social medicine in medical schools around the world. And one of the distinctions is that is of interest to us here as we're trying to understand this, is that an organization like Partners in Health, an NGO founded by Dr. Paul Farmer, says it's essentially the marriage between medicine and social sciences. We don't just look at the biological determinants and medical determinants and molecular explanations for bad health. We look at what social science can tell us. And that's why it's useful to have in this room law students and students of political science. So it covers a wide range of topics, and the essence is, as you quite rightly pointed out, touch on the intersection of society and health, focusing on socioeconomic factors that affect health. Now, here's another distinction we need to make. Social medicine is a domain that people in medical schools study to take into account what they can learn from the societal factors that affect good health. Public health is a different training program. It's a different professional training. The understanding of the social factors and the psychological factors that affect people's health is extremely valuable for the doctor who's administering to patients. But public health is a related field that also draws upon this broader framework. It overlaps, the social medicine overlaps with public health. But public health emphasizes policies and practices for populations, not for your client, not for your patient. And of course, the social conditions do play an enormous role in how you can improve the health of your patient. But in public health, we focus on population concerns. What policies and practices will affect the population more broadly. So, the important takeaway here is that social medicine was emerging as a concept. And this gentleman here, who is one of a handful of people who were writing on it and articulating it and making this a point, was a friend of the delegate of Yugoslavia during the conference that examined, that drafted this document. And there's an interesting process here. Interesting that you mentioned the World Health Organization. Yes, you would think the World Health Organization would be the first place where you'd find this awareness. And in the spirit that prevailed in 1945, during the drafting that led to the 1946 Constitution of the World Health Organization, this was the spirit. We have just emerged from a great war. Millions of people were killed. We have lessons of previous centuries of what needs to be done for health. We want to create organizations that can help us do a better job. And the World Health Organization, in order to do a better job, needs to build into its understanding of health that it's not just the absence of disease and infirmities, but it deals with the social, what we call today, the social determinants of health. The reason I'm emphasizing this is that those who have studied the role of the World Health Organization on the right to health acknowledge that it played a role in the founding document because of the Yugoslav delegate and his being influenced by the founders of social medicine. But the World Health Organization also brought in the specialists that you'd expect in the various domains in which the World Health Organization operates. And they went back to, after the adoption of this document, they, after a few years of cooperating and trying to establish institutions promoting health as a human right, they went back to being more technocratic. And they've been criticized for this. There are various scholars who have analyzed the history of the World Health Organization, started as the leader in articulating this view, and then took less of an interest in health as a human right and more of an interest in the various means and methods of achieving their purposes on specific health-related issues. And then it came back up, and today there's much more of an acknowledgement of the relationship between human rights and public health in the World Health Organization. So the reason I mention that is that in the history of human rights, this moment of 1946 preceded the inaugural document of human rights in the contemporary world that occurred 2 years later. This is 1946. 2 years later, what happened in human rights? Okay, Universal Declaration of Human Rights. You have the brightest student in the class here. So, I'm going to come to the Universal Declaration of Human Rights because what we will discover is that the preamble to the Constitution of the World Health Organization was far in advance of the understanding of health as a human right than the authors of the Universal Declaration of Human Rights. So the emergence of the concept of a right to health has this strange tension between World Health Organization, social medicine, a clear allusion to physical, mental, and social well-being. And so at the time, and even today, there's an interesting debate on whether that definition that you liked, because it covered physical, mental, and social well-being, whether these concepts that relate to also to vital energy, meaning and purpose in life, connectedness to community, and so on, all these dimensions, complex philosophical concepts that, let me see if this works with the button. No, it doesn't. No, so I'll just point to it. So well-being, if that's what it's all about, to achieve well-being of a human being, you need to take into account these dimensions. Well, people working in public health raise doubts about that. The concept of complete physical and mental well-being was questioned, for example, by a leading philosopher and ethicist in public health, Norman Daniels, who said the WHO definition risks turning all of social philosophy and social policy into healthcare. And he said, if we want to know what health is, and this is a leading figure in understanding the ethical foundations and the philosophical foundations of public health, he said, this doesn't help us. This broad definition of physical, social, and economic, social and mental well-being, why don't you even add spiritual well-being? And I'm going to come to that in a minute. He said, no. This is going to turn the definition into something that's useless. In health, we need biostatistical markers. So if you want to know if health is improving, you want to know if maternal mortality is going down. You want to know if prevalence of HIV/AIDS is going up or down, and so on. That's what you need to know. A philosophical concept of social philosophy, of social policy on physical, mental, and social well-being. That's a problem. We don't need that. That's going to ruin our work. How can we advance public health if we're going to focus on these broad social concepts and so on? Even another philosopher, Cicely Bach, said that adding the word complete, because she's a philosopher who takes language very seriously and meaning very seriously, complete social well-being, that adds to the confusion. We want to improve people's health. How do you get complete well-being out of that? So, conceptually, it has been challenged. And let's see. I want to go back to the core definition. If you accept that we can have this broad definition inspired by social medicine, and you quite rightfully pointed out physical, mental, and social, if you're going to be that complete about the well-being of a human being, is there something missing that I mentioned briefly just a minute or so ago? What would you, is that, if you're allowed, if you say, no, you don't have to listen to Cicely Bach, you don't have to listen to Norman Daniels. You can listen to those who want to embrace the full human being, the well-being of a human person for flourishing as a human being. Physical, mental, social. Anything missing? Environmental. So that's your relation to other species and to the earth. Anything else missing? Spiritual. And guess what? Adding spiritual, we'll come to environment later. It's going to be an important part of it. Spiritual was proposed by yoga is part of it, certainly, and certainly now, of course, in the health field, the value of yoga, which is not just a physical exercise, it's also a spiritual exercise, has been widely recognized. And there were many people in that room, you can see them there, who, including the Indian delegate, who valued very much the spiritual dimension of well-being, but it was rejected. And in many efforts to build on this definition of health as complete physical, mental, and social well-being, efforts have been made to add spiritual. And actually, it did succeed in one case. One of the things we're going to look at when I get to the formal definition of the right to health as it moved from this preamble to a constitution to an actual binding treaty, is that one of them did add spiritual, and that's the African Convention on Human and People's Rights that added spiritual to the definition. But for the most part, the core definitions in the United Nations has respected those who wanted it but did not agree to it. And one of the reasons is, of course, at that time, the world was becoming bipolar between essentially Western liberal democracies and socialist countries. With the beginning, the emerging, and India, of course, played the leading role in this, being ahead of most other newly independent countries, those who were liberating themselves from the yoke of colonialism had other agenda items. But at the beginning stages, in the 50s and 60s, it was still Western liberal democracies versus communist states. And of course, the communist states that disregarded religion as being inconsistent with the Marxist-Leninist analysis of society firmly rejected adding spiritual here. But there is the broad framework of human well-being in which you spontaneously added to physical, mental, and social, you added environmental and spiritual. And that's definitely part of it as it has evolved. So this framework can be determined by some philosophers say it complicates things. So the question then becomes, is this an obstacle or an inducement to doing better for advancing the right to health? And that's what we're going to see happens as we move ahead here. So step one, the broad definition, excluding spiritual, but being quite broad, drawing on social medicine in the Constitution. Step two, 2 years later, the Universal Declaration of Human Rights was adopted, and Article 25 refers to the right to an adequate standard of living. Just a few words here. Including food, clothing, housing, and medical care and necessary social services. That's minuscule. Medical care. Okay. So there is a right to an adequate standard of living, and the Universal Declaration of Human Rights limited its references to health to this framework. It's a very important framework. An adequate standard of living is a very important human right. But at that stage, no real definition of the right to health. The best definition we had at the time was in the Constitution of the World Health Organization, the highest attainable standard of physical and mental health, which didn't even reappear in the Universal Declaration of Human Rights. Now, Universal Declaration of Human Rights is the starting point of the modern movement for human rights, which draws upon, and I had the privilege of working in the United Nations Educational, Scientific, and Cultural Organization, which actually in 1947 organized a conference on the philosophical foundations of human rights if the international community decides to adopt an international bill of human rights before the Universal Declaration of Human Rights. And at that conference of the philosophical and spiritual leaders of the world, there was an enormous opening to a broader understanding of human rights. It got narrowed in the Universal Declaration of Human Rights. And then the project that remained was how to translate the Universal Declaration of Human Rights into something meaningful that makes a difference. From rhetoric, a declaration, which is non-binding, to reality. How do you affect the laws, policies, and practices of countries so that human rights becomes a reality, including the right to health, limited for the moment to an adequate standard of living. What, in your knowledge or understanding, is the next step from medical care as part of the right to an adequate standard of living to a human right to health? What would be does anybody know, especially those working on legal aspects here? What's the next step? Or are we still just saying the only international document we have on the right to health is this one, Article 25 of the Universal Declaration of Human Rights? That's it. That's the reference. You want to know about right to health? I'll tell you. It's Article 25. Or do we go further than that? Does anybody know? No? Okay. So I'll walk you through it. Following the adoption of the Universal Declaration of Human Rights, the civil society organizations and the United Nations organizations proceeded to, well, they adopted a few small conventions, on refugees, on right to rights relating to consent in marriage and things like that. Some issues, some human rights issues that were not major ones, but that were kind of translating a human rights framework from declarations to law, to binding conventions or treaties. This culminated in the adoption in 1966 of two international covenants. Does anybody know what these two covenants were or are? So none of you have had training in international human rights law. So this will be very basic then. Yes? ICCR and? ICCPR and ICESCR. Okay, so smart people, and all of you young people, political scientists and lawyers, if you want to impress people in the human rights world, just toss out ICESCR, ICCPR. You don't know what does that mean? ICCPR. Can you tell us? That's good. I want you to say no because you're not supposed to know. How about you? Can you tell us? All right. ICCPR is the... So you do. You see, I have to thank you for letting me know that you have more knowledge than I thought you had. All right. So in 1966, the Universal Declaration of Human Rights was translated into binding legal norms. The International Covenant on Civil and Political Rights and the International Covenant on Economic, Social, and Cultural Rights. Now, who can tell me why the Universal Declaration of Human Rights, one document, when transformed from a non-binding declaration of principles to a binding treaty, had to become two documents? Why two? Why didn't we just take the Universal Declaration of Human Rights and rewrite it in greater detail with attention to what can be binding legal norms? Somebody knows, because you're very smart. You hide your knowledge, and I have to press, and then I find out that, yes, you do know what ICCSCR is and ICCPR is. So who can tell us, why do we get an international covenant on civil and political rights on the one hand, and an international covenant on economic, social, and cultural rights on the other. The purpose was to move the Universal Declaration of Human Rights into binding law. So why not do it?
Because both of them are focused on two different aspects. To make it more detailed, UPHR one document may be vague in that sense, because these two are more detailed, and then making it binding for the countries to develop.
So the suggestion here is that it's because if you're going to write binding documents, you're going to have to go into detail, and we need to distinguish these categories of rights and in doing so, we have different approaches to defining legally binding obligations. That's one explanation. And that explanation is predicated on the idea that sometimes people call civil and political rights negative rights. In other words, they say the state must leave you alone and not do things that interfere with your life. Right to privacy, right to be free from arbitrary arrest and detention, freedom from torture. Those are negative rights. Economic, social, and cultural rights are positive rights. That means that you're not going to get those rights unless the state does something for you. Any reactions to this? Is this a convincing separation of rights? Because? There's the other dimension. All right. So, it is true that there are philosophical discussions about positive and negative rights. These rights are different. One requires allocation of resources from the state. The other simply requires that the state abstain from violating your rights. These different explanations. But the real factor behind this was, during the Cold War, I was explaining earlier how Western liberal democracies and communist countries diverged until the non-aligned movement exercised its influence on international politics. But this tension between communist countries and capitalist countries, if I can oversimplify, led some to attach importance to economic, social, and cultural rights because that's what communist countries put in their constitutions. Communist countries believe that the right to work, the right to health, the right to an adequate standard of living, the right to Social Security, and so on, was a victory of the working classes against the dominating classes. That's what human rights are all about. And Western countries said, yeah, those are social programs, you do that in government, but rights are those that are fundamental to being a human being. So those are the civil and political rights that define the rights. So under those tensions, the solution of the Commission on Human Rights at the time was to draft two separate instruments. Now, obviously, we are looking for the definition and expansion of the right to health. So, which international treaty would you expect to find that in? The Covenant on Economic, Social, and Cultural Rights, or the Covenant on Civil and Political Rights? Come on, somebody, to show me you're following. Two draft documents. Cold War, one document called Covenant on Economic, Social, and Cultural Rights, the other one called Covenant on Civil and Political Rights. You want the right to health. Which one do you put it in? You. Yeah, no, I'm asking you if you can help us out here. Where do you put it? If you're going to come with the right to health, and there are two documents being drafted, one called the Covenant on Civil and Political Rights, the other one called the Covenant on Economic, Social, and Cultural Rights. Where do you go for the right to? You can help? Of course. That's very straightforward. So, and here we are in Article 12, which is the core definition of the right to health, that is a big jump from the UDHR, reflects the World Health Organization's definition in the preamble to the Constitution, and has been since this moment in 1966 the core definition that has continued all over the world in all other treaties and so on. It is the real starting point, is Article 12.1. Everyone has the right to the enjoyment of the highest standard of physical and mental health. So that is one of the takeaways of this talk today. Not only will you be able to show off to people that, yes, ICSCR, ICCPR, okay, you'll show that you're knowledgeable about the main human rights documents that are binding in international law, but when it comes to the right to health, the starting point is essentially Article 12 of the Covenant on Economic, Social, and Cultural Rights. Now, in that same Article 12, there was a second paragraph. First paragraph is general. Everyone has the right to the highest attainable standard of physical and mental health. Second paragraph was to say, okay, we're not that limited. We can, since 1946, when this same standard of Article 12.1 was reflected in the preamble to the Constitution of the World Health Organization, we can go further than that. We've been investigating this. So let's give some examples, some non-exclusive examples. And paragraph 2 refers to the provision of stillbirth rates and infant mortality for the healthy development of the child, environmental and industrial hygiene, prevention and treatment of diseases, and medical services. All right, so at that time, when there had been an effort to identify what are the elements of this, we can't just say the broad, we can't be, we have to listen to people like Norman Daniels, who says, that's useless to have this broad, confusing definition. We have to say what we really mean. So we, working in the health field, know that whatever the right to health is of paragraph 12.1, we want to make sure that you understand, as you try to apply this legal obligation for the right to health, that you do focus on the healthy development of the child, environmental and industrial hygiene, prevention and treatment of diseases, and availability of medical services. Okay, that's almost a random list if you take the medical need, the health needs of a society. That's almost a random list. But at least it's taking us farther than a vague definition. Now, that definition of Article 12.2 became the standard reference for international human rights documents that either took the same words or some version of those words. And you'll find the right to health in the other human rights treaties. For those of you who don't know the history of international human rights, we have the Universal Declaration of Human Rights, 48, Covenants, 66, and then for the next 20 or 30 years, identifying major issues that called for more detailed binding treaties. And these related to racial discrimination, to discrimination against women, to torture, to rights of the child. These are all issues that emerged as saying these are areas where we need more than the Universal Declaration of Human Rights. So, in the 1965 Convention on the Elimination of All Forms of Racial Discrimination, and in the Convention on the Elimination of All Forms of Discrimination Against Women, and the Convention on the Rights of the Child, and the Convention on the Rights of Persons with Disabilities. All of these treaties also contained a paragraph on the right to health inspired by Article 12. So you take the Convention on the Rights of the Child, the right of the child to the enjoyment of the highest standard of health and to facilitate the treatment of illness and rehabilitation in health, and it enumerates then 6 measures that need to be taken. And that's one example of a treaty that incorporates into it. The treaty is focusing on a category of subjects of rights and make sure that it is compatible with, although not always identical with, the formulation of the right to health in Article 12. So those are the major human rights treaties of the UN. So we come from Universal Declaration of Human Rights, Covenant in 66, all the treaties of major categories of human rights that contain their own article on the right to health, and at the same time, human rights law expanded from United Nations meetings in New York and Geneva to regional organizations. The Organization of American States, the League of Arab States, the African Union, the Council of Europe. All these regional organizations established human rights treaties and human rights mechanisms with commissions and courts to decide human rights cases. And each of those regional organizations also incorporated provisions relating to the right to health. Now, in the European Convention on Human Rights, one of the first and most powerful instruments in human rights because it had a court that could decide if there are violations and take measures against the state responsible for a violation of human rights. The European Convention on Human Rights was essentially civil and political. And to supplement it, the Council of Europe adopted the European Social Charter in its revised version of 1996, has an Article 11 on the right to health. The African Charter on Human and People's Rights has an article on the right to health, which includes spiritual well-being. The American Convention on Human Rights, which is the human rights treaty for the Organization of American States, North America, South America, Central America, Caribbean, all of these countries have a regional organization called the OAS, and it has a regional human rights treaty. That was essentially also civil and political, like the European one. So it added an additional protocol in the area of economic, social, and cultural rights. And there too, you have an Article 10 on the right to health. And the revised Arab Charter on Human Rights also contains a provision on the right to health. So you can see that UN organizations in expanding human rights in areas relating to disabilities, women's rights, racial discrimination, and so on, and regional organizations developing their own human rights frameworks, all incorporated the right to health. So we are moving from this tiny reference to medical care in the Universal Declaration of Human Rights to an enormous array of human rights treaties incorporating a right to health modeled on Article 12 of the ICESCR. Now, I'm wondering if I'm boring you too much and you want to... Is this clear to everybody? Does anybody have any questions? Do you feel comfortable understanding how the right to health started with social medicine influencing a Yugoslav delegate in Geneva, adoption of the Constitution of the World Health Organization, building on their Universal Declaration of Human Rights, covenants, treaties, regional treaties. Is that clear? Okay? No questions? All right. So I'll assume that you've assimilated that. Now, yes?
I have a question, I can ask you later also, but recently there was a news that a girl, Dutch girl, 29 years Dutch girl, she chose to get euthanasia because she has a mental issue which is beyond curable, and it was permitted.
Yes.
So on what
Yes.
or it's a very nice positive, but don't it have a negative impact on our
All right, this is another example, this question of euthanasia for a girl who, what age was she? She was a minor?
She was 29 years.
29 years old. So an adult who seeks to end her own life. Is that it? So if there is a right to health that's related to a right to life, is it related to a right to death? And the right to death has been debated not back then when it was hard enough to get this enumeration that I showed you in Article 12, Paragraph 2 of the ICSCR. But the question of where the right to death fits into human rights didn't emerge until the 1980s and 90s. And then there have been legislations in different countries and discussions of this, but no formal, and I'll go into greater detail on this later, but for now, there's no formal right to die in any of these human rights treaties. It has been examined from a human rights point of view, and in fact, there's what's her name? Liz Wicks of the University of Leicester has recently published a book on suicide and human rights. And there have been a lot of discussions on this. And it is a deep philosophical question and a practical question of when do you permit people to end their own lives, under what conditions, and so on. And there's no straightforward answer to that. There are countries that prohibit this, and if they're going to give it a human rights explanation, they're saying it is our duty to protect the right to life. People cannot take a life away. Suicide is a violation of the right to life. Others have other arguments based on human dignity, on reduction of suffering, on the agency that the individual has, and that respect for that agency should allow the individual to determine the timing and means of end of life. And there are many variations in between. So there's no uniform international standard on this. But it was not discussed at the time of the emergence of these international and regional instruments. Now, so we have the texts of all these UN treaties and regional treaties that say everyone has the right to highest attainable standard of physical and mental health. As you know, and those who don't know, let me give you a quick lesson on what I'm going to come to later on the implementation of human rights. When you adopt a treaty, like the International Covenant on Economic, Social, and Cultural Rights, that doesn't just sit in a library in Geneva. It is also it creates legally binding obligations on states like India to do certain things. One of the things they have to do is to report back to the UN on what they have done to carry out their obligations. They have legal obligations. So it is part of their other procedures of complaints and so on, but I'm focusing now on what's called the reporting procedure. All countries must report back regularly to a body created for each of those treaties, called the treaty bodies. And the Committee on Economic, Social, and Cultural Rights is the treaty body that examines the reports that come from countries on what they have done. In examining these reports, the members of the committee over the years say, yeah, we've been reading all these reports and what they've done on the right to health, and sometimes they refer to maternal mortality, and that's all we get. Other cases, they talk about sanitation issues. We need to help these governments give us something that's useful to us so that we can tell them, you could do better, or congratulations, you're doing a good job, or you could do better. That's their job. The treaty bodies tell the governments that they've done a good job or a bad job and where they can improve. Now, when they discover that they're getting sometimes nonsense or useless information from governments, you can't just give a lecture to the government on how they could do better. They needed to clarify the nature of the obligations. And this is a procedure that those of you in political science and law that are studying how this works in international human rights, it's a procedure called general comments. These committees examine reports, but they also issue general comments in which they interpret the treaty in a way that they hope will help the governments do a better job of fulfilling the treaty. And the general comment on the right to health is General Comment 14 of the Committee on Economic, Social, and Cultural Rights, in which the committee tried to clarify what are the obligations we're really talking about on the right to health. What do you need to do as a government? And it came up with the 3 A's and a Q: availability, accessibility, appropriateness, and quality of care. And this is the official document where it appears. So this is where you know that this, and in fact, there have been many general comments of the various treaties. There are general comments on the treaty, on the Convention on the Elimination of All Forms of Discrimination Against Women, on racial discrimination, on rights of persons with disabilities. These are all very important documents. Sometimes the general comment has become a major standard reference used all over the place, including in national governments, in NGOs, and so on. So some of them are just routine clarifications, and specialists might look at them and so on. Others have risen to the level of a standard reference, and General Comment 14 is one of those. This page in which the Committee on Economic, Social, and Cultural Rights in the year 2000 clarified that the right to health has the following interrelated and essential elements. So this is not new rights. This is an interpretation of the right in Article 12. This is what Article 12 really means. It means that functioning public health and healthcare facilities, goods and services, as well as programs, have to be available in sufficient quantity within the state party. That's what we mean by availability. They did the same thing on accessibility and appropriateness. Oh my goodness, I've repeated that twice, sorry. And acceptability and quality of care. Acceptability is an interesting one, because acceptability includes two things. This is important, and you can understand why the committee wanted to clarify this. Acceptability means that it has to be culturally acceptable. So that means that in a country where I can give lots of good examples of this. In a country where there's a great deal of sensitivity to gender issues, there are circumstances in which a male doctor will not be expected to examine a female patient. And this is evolving, but that's the appropriateness of care. Obviously, if you're going to provide food services in a medical facility, you're not going to provide beef to a Hindu or pork to a Muslim or a Jew, and things like that. So that's appropriateness of care. Second meaning of appropriateness in this expansion of the understanding of the right to health is ethical standards. In the health field, as you know, bioethics and ethical standards and institutional review bodies that examine the ethical standards that apply to medical and health practices also have to be respected. So that's another one of the things they reminded countries. You're going to implement Article 12? We want you to make sure that the facilities are available, accessible, appropriate, and of high enough quality. I have to clean up this slide. I'm very sorry. Don't use that slide. Use the actual text of the of General Comment 14. Now, so that effort, you see where we're moving. Tiny definition of the right to a firm definition of the right to the proliferation of that right in treaties. That's essentially Article 12 right as it appears in all the regional treaties and the international treaties. Then clarification of what we mean by that right. Not a new right, nothing new. We're just saying this is what we mean by it. General Comment 14 did that. Also, the Office of the High Commissioner for Human Rights, with the help of an Indian former official of the Ministry of Finance, and before he came to the UN, and then after he came to the UN, colleague of ours at the Jindal School of Government and Public Policy, Rajiv Malhotra, produced for the UN a set of indicators on human rights, and applied his knowledge as an economist and so on to trying to get a deeper understanding of how we can measure the realization of rights. And when it comes to the right to health, he found these attributes. He's saying that it's not in the treaty, it's not in Article 12, or some of it is in Article 12 too, but not all. But in my understanding of what's going on in this health field, these are the areas we need to cover. Sexual and reproductive health, child mortality, natural and occupational environment, prevention, treatment, and control of disease. This is an updating with indicators of that non-exclusive list in paragraph 12.2 of the International Covenant on Economic, Social, and Cultural Rights. So this is another way in which not the right hasn't been expanded, its understanding has been clarified. And a lot of this comes also from litigation, from case studies. And this is a book on litigating health rights. And it's based on case studies from Costa Rica, South Africa, India, Brazil, Argentina, Colombia. And it looks at how courts have taken the right to health and clarified its meaning and applied it and given legal consequences to it. And as you all know, probably much better than I do, that in 1996, the Supreme Court of India interpreted Article 21 of including the right to health, and the National Commission on Human Rights drafted a charter on patients' rights, and so on. And one state, the state of Rajasthan, in 2022, adopted a Right to Health Act. So you can see, and it's been criticized, but it's been a major application of the interpretation of Article 21 by the Supreme Court in the state of Rajasthan. And I think to date, no other state has done this, yet taking seriously the right to health. And it includes quite a few rights for everyone: the right to emergency treatment, the right to informed consent, the right to confidentiality, referral transport, quality of health care, grievance redressal, and for residents of Rajasthan, additional rights of free health care services and free transport and that sort of thing. So,
Sir, Assam has a law that in case of accident, the first 24 hours of service,
yes,
no private hospital can deny.
no private hospital can deny it.
First 24 hours of emergency service they have to
Yes.
provide.
So that's a way in which national or state legislation has implemented the broad concept of the right to health and implemented it locally in ways that affect people's lives. You must get that treatment, emergency treatment, without cost, including from a private facility, as you pointed out. So, what I've said so far is the definition and clarification of the right to health, where it came from and what it means, and how it is applied all over the world by national courts, by regional human rights bodies, by treaty bodies, and so on, all building on essentially Article 12 of the International Covenant on Economic, Social, and Cultural Rights. That's kind of the core right to health. What I'm going to do for the rest of this session is to talk about how it's expanded from those elements of the 3 A's in the Q to more, to new ideas, ideas that were never thought about in 1966, that nobody would have imagined. But before I do, I want to take a break and try to get some feedback and so on. Do you feel you've got an understanding of this now, of what the right to health is in its core definition, where it came from? Anybody have any questions? Because what I'm going to do now is to go to what I call the normative expansion. But before I do the normative expansion, I want to be sure that everybody understands the emergence and content of the norm. So the norm is the right to health. You know where it comes from, and you know what it says, right? If I were to give you a quiz right now, an exam paper, where does the right to health come from? You'd write a good paper, wouldn't you? Okay, I'm looking around to see if there's any doubts. Okay, if you feel comfortable with that, can I move on? I'm going to take a break. Yes. Oh, good. A question.
Like, all this you see a deviation from all this norm during the COVID period.
Yes.
COVID period is like we have to prioritize our other rights, civil liberties, sports, even economic rights.
Yes.
And we were also told that the vaccine is safe for human body, and all of us has taken it. But right now we came to know from various reports that it has some health risks. And our certificate, which came along with the pictures of the Prime Minister, is also suddenly
Yes.
certificated. So now, who is the state obligation, or who is in case of the consequences of vaccine that we is facing, the long-term consequences, health consequences?
Yeah.
Who is responsible? How is the state accountable?
All right, so the question has to do with responses to COVID-19, especially in India, but different responses across the globe, in which efforts to address the needs of the population to protect them from getting COVID-19 or being treated after they got the virus has resulted in, I think, correct me if I'm wrong, but I think you're asking two things here. In the effort to do the right thing to help people, to address people's health needs during COVID-19, other human rights were violated. People were forced to move. People in India had to walk hundreds of kilometers, and many people died in the process. Newspapers were denied the right to publish the facts, and things like that. So how do we balance human rights in general and addressing the health needs during a pandemic? I think that was the first part of your question. And the second part of your question had to do with...
And the accountability regarding the consequences of COVID-19 vaccines.
Yes. So the choice of the vaccine that has been used, and there have been various vaccines that have been used, some of those have had negative consequences. What's the responsibility of the state who distributes it? if you do not properly test because of the urgency of millions of people getting infected, you have to move fast. If you move too fast before you've tested a vaccine and then you discover later these consequences, what is the responsibility of the state? And all of these issues are being examined in great detail by various human rights procedures. The short answer to the first part of the question is that there is a framework in human rights called human rights in exceptional circumstances of two types. One are exceptional measures can reduce the enforcement of a human right or alter certain human rights to meet certain needs as long as they meet the criteria of necessity and proportionality. Example, during an epidemic, freedom of movement, freedom of residence, obviously you have to put restrictions on that. Now, it's also a question of, and freedom of religion. People want to go pray, they pray in a temple or a church or a mosque in a crowd. And that's how diseases are spread. So, there is a provision of human rights law that allows for exceptions, exceptional circumstances, for restrictions on rights to respond to needs of public health, national security, and so on. Those must be subjected to the test of necessity and proportionality. It would take me the next 3 or 4 hours to go into all the details of that, but in the case of COVID-19, there have been cases where reasonable restrictions on freedom of movement, freedom of residence, freedom of religion, and so on have been applied, and there have been cases where certain human rights bodies have examined what's been done and the government's gone too far. They don't meet the criteria of necessity and proportionality. And then the responsibility of the government, that's also another extremely complicated issue, that the government has the responsibility to make vaccines available to the population and has to overcome the obstacles to that, which include the price of the vaccines, which relates to intellectual property rights, and so on. That's an obligation of the state under the right to health. But if along the way, in your sense of urgency to respond, you end up distributing a medication that causes harm to the population, is that a violation of the right to health, and so on? There's no simple answer to that. That's a matter for the public health facilities to address quickly, to draw upon international cooperation, and that's where international cooperation comes into the picture. Now, I wanted to give another perspective on when can human rights be limited? And we saw that an exception is allowed for the needs of public health under certain controlled conditions. There's a second concept of international human rights law, which is that of derogations in time of public emergency threatening the life of the nation. So if there's a civil war, an international war, a major catastrophe, a disaster, and sometimes an epidemic can reach that proportion, where the life of the nation, in the terminology of the human rights documents, is threatened, then certain human rights can be suspended. Now, in the case of COVID-19, even though it was a major emergency, it was not regarded to fit into that category of a national emergency threatening the life of the nation, so that certain rights could not be set aside. But limitations were certainly allowed. Limitations were allowed and expected, and from a human rights point of view, you have to examine the provisions of human rights treaties that allow for limitations where necessity requires. Now, your question is such a deep one, though it would require a lot more to go into detail. What actually happened in India? What were the provisions? Have there been any human rights controls? Obviously there have been, but we could do another lecture on that later. What I wanted to get into now is we've got the right established all over the world. We've got the interpretation of the right as defined. And now we're going to move on to what I call normative expansion. Normative expansion is an idea that is kind of self-definitional. That means you take a norm, a standard, and your understanding of it, your willingness to interpret it, expands. There are more things that relate to, in our case, the right to health, that weren't thought of. They're brand new. Or they were kind of suppressed. And social norms, that's why I start with the reference to social norms, evolve. And so the attitudes, if you think about, if you have never thought about social norms, just stop and think for a minute about slavery in antiquity, or torture in the Middle Ages, or women's status 100 or 200 years ago, where it was simply part of society. There were slaves and slave owners. That was society. Went on for centuries like that. And that was acceptable norm. That's the way people lived until more social norms changed and the abolition movement eliminated slavery. Women's movement moved women away from a subservient, subaltern role in society to more and more measures to assure equality. That struggle is still going on. The struggle against racism is still going on. But the norms, the social norms have changed. That's what we mean by the involvement of norms. And now there's an evolution on LGBTQ rights, which a few decades ago, most countries wouldn't even think, we can't touch that, we can't go there. We're either going to suppress them, we're going to criminalize it, whatever you're going to do, or in case of some countries, apply the death penalty to anybody engaged in same-sex behavior and so on. But the norms are changing, we know that. We know that in most societies, laws are being adopted and court decisions are being made to protect equality of rights among these different categories. So, in the context of evolving social norms, we have to adapt. So, in the case of the right to health, there were things that people drafting Article 12 never thought about, that have emerged as being really important health issues and have been incorporated into the official references in different ways to what constitutes the right to health in its broader sense. We saw it was broadened by such things as this and General Comment 12. That broadened the understanding of it, but not the content of it. The content was broadened by the proliferation of rights, new rights. And here there's a deep question that the political scientists, lawyers, philosophers, social scientists need to reflect on carefully. If we add more rights, is that a good thing or a bad thing? If we call everything a right, a human right, have we, of course, we saw the evolution from the WHO Convention, Constitution, to the UDHR, to the covenants and so on. Okay, we understand that progress. But tossing in all kinds of new good ideas, where does it stop? When, in the question I've asked it here, does the proliferation weaken human rights internationally? Does it become mere rhetoric if we start calling other things a right? And that's what we're going to look at now. I reflected in an article a decade ago on the normative expansion of the right to health, and so this is what I'm drawing from in discussing the proliferation of human rights, and the normative expansion of the right to health. Now, you've seen the general comment that expanded the understanding of the content of Article 12. There are essentially three tools of normative expansion. One is the one we've just discussed. You clarify and provide your 3 A's and a Q and various means of and illustrative steps as we saw. The second one is the interpretation of article, as we saw in General Comment 14, in which they defined, in addition to those attributes that I listed, the 3 A's and a Q, they also listed the essential elements, core minimum, equivalent obligations, and so on. And then there are proposals for new rights that have come up, and that's what I want to talk about now. New rights. Let's take a look at some examples. Well, let's first look at the challenge to new rights. The founder of utilitarianism, Jeremy Bentham, that's supposed to be the actual body of Jeremy Bentham, who's kept in a box at Oxford University or Cambridge, I forget which. He reflected when the French Declaration of the Rights of the Man and the Citizen was adopted in 1789. A few years later, he looked at what they adopted and he said, these rights of man in the French Declaration of the Rights of Man and the Citizen are rhetorical nonsense. They're nonsense upon stilts. They're mischievous nonsense, dangerous nonsense, miserable nonsense, rueful nonsense. He even called it terrorist language. And so we're talking about the 18th century now, where he challenges the French Assembly that adopted the Declaration of Human Rights, that has been kind of a starting point for the modern human rights movement in constitutions. And he's, as a deep thinker, said, you can't do this. You can't just put on a piece of paper that something is a right and it becomes a right. Other more recent people, this is a famous political scientist and social scientist who said that in the beginning of this century, he said that rights industry has grown faster than an internet IPO. We have animal rights and women's and children's rights and gay rights and rights of disabled and handicapped, indigenous people's rights. Oh my God, given this monumental confusion, let's just abandon rights altogether. So there is the reaction against the expansion of rights. He knows that the rights in the US Constitution that he was thinking of, those are fine. But if you're going to talk to me about the rights of handicapped and the gay rights and indigenous people's rights, that just weakens, it dilutes human rights. Human rights loses its meaning. So that's what you're up against when you want to add new rights. Another scholar has talked about a surplus of human rights. They're claimed to be equally important. We're reaching the slow bursting of the human rights bubble. So when you talk about all these different rights, this fellow says, you're doing this, putting too much inside and it's going to explode. There's no more human rights. It's just going to be the end of human rights. And on the right to health, this very prominent former governor and leading person in the American Bar Association says you can't consider health care a right. If everything a right, then nothing is a right. You dilute the important meaning of the word by claiming idealistically that all good things are rights. So there's the challenge. I think he put that quite well. If you take anything that you think is a good thing, and in his case, even saying health is a right, it's not going to work. That's idealistic, and it dilutes the meaning of rights. Contrary role, take this doctor who was put in charge of HIV/AIDS for the World Health Organization. And he was a doctor worked in public health, various public health departments, worked for the World Health Organization, head of the AIDS program there. And he came to the realization in the field of AIDS that we really don't understand this problem of AIDS by using exclusively the public health lens. It is only, we can only address it by using a human rights lens. And his words are actually quite prophetic, and I'm going to tell you why in a minute. When he said, modern human rights, precisely because they were initially developed entirely outside of the health domain and seek to articulate societal preconditions for human well-being, are a far more useful framework, vocabulary, and form of guidance for public health efforts to analyze and respond directly to the societal determinants of health than any inherited from the biomedical and public health traditions. His point there was that as a medical practitioner, human rights didn't dilute things, didn't weaken things, but strengthened things, made a big difference. And this was, in fact, the beginning of the health and human rights movement. As a result of this, the Journal Health and Human Rights, the Center on Health and Human Rights, all of these bodies have emerged building upon Jonathan Mann's efforts. Now, but what about international human rights law? How do we... Certainly, Jonathan Mann argued why it is so important for health to be a human right. That's the answer to the lawyer and governor that I showed previously. He said you can't just call health a human right. It dilutes human rights. He says, no, it's essential to call health a human right. But if you're going to expand and call other things human rights, where do you draw the line? Well, the General Assembly of the United Nations, under the influence, in fact, of an Australian scholar who is an international human rights scholar named Paul Hunt, who was actually the special rapporteur of the United Nations on the right to health, wrote an article on new human rights and how we should, when we should decide something deserves to be called a new human right. And this influenced the General Assembly of the United Nations that adopted in 1986 a resolution providing these 5 conditions. We will not adopt anything as a human right unless it's consistent with current human rights law, fundamental, it's precise enough, it provides effective implementation, and it attracts broad international support. Okay, that's reasonable, I guess. So then what do we do? So there have been many candidates for this. In addition to the right to health, the right to water and sanitation, the right to safe motherhood, the right to tobacco control, the right to essential medicines, the right to essential surgery. These have emerged as priority issues in which people said, I work in public health, this is important. In fact, it's so important, I'm going to call it a human right. This is normative expansion. This is what we're talking about. So, how do you feel about normative expansion? Can I give you some examples? In fact, these are the examples I propose to give you. Let's take the right to water and sanitation. It's not in the Universal Declaration of Human Rights. It's not in the Covenant of 66. It's not in the regional treaties. It's not in the other human rights treaties. The same Committee on Economic, Social, and Cultural Rights in 2002 adopted a General Comment 15. How interesting. General Comment 14 was on the right to health. General Comment 15 was on water. And at the same time, the United Nations Development Program issued a report called Beyond Scarcity, Power, Poverty, and the Global Water Crisis in the early 2000s. And at that point, the United Nations Development Program had identified the real threat to the lives of people all over the world resulting from water scarcity. And then the General Assembly, after a resolution was adopted by, I'll come to those now, I think. Yes. So General Comment 15, this was the document that came after General Comment 14 on the right to health, discussed the importance of the right to water. And then the General Assembly adopted in 2010 a resolution that recognizes the right to safe and clean drinking water and sanitation as a human right that is essential to the full enjoyment of life and all human rights. So there you are. If we go back to this, have we met this criteria? 1, 2, 3, 4, 5? Can we declare that water is a human right? So, conditions are met, we're comfortable, but what have you just done? Normative expansion. So there was no right to water before this was agreed upon. Sorry. But this resolution of the General Assembly affirmed the right to safe and clean drinking water and sanitation as a human right. A few years later, another resolution focused on sanitation. Water and sanitation usually go together, and so in this resolution of 2015, the right to safe drinking water and sanitation, the human right to sanitation was defined as entitling everybody without discrimination to affordable access to sanitation and so on. And you know how important this is in India. Well, I won't get into the... Yes, he's distributed a lot of toilets that are not being used. Why? Because there's no water to use them. So it's not factual. But the starting point, from the normative point of view, is I think, something we can easily agree upon. Everyone has the right to sanitation. 600 million people defecating outdoors is not consistent with our understanding of human rights. There's a right to sanitation. And this has been affirmed by Resolution 7169 by the General Assembly of the United Nations. So the 2015 resolution emphasizes more the sanitation dimension along with the right to water. The human right to safe drinking water entitles everyone without discrimination, etc., etc., etc. So here is an effort at normative expansion, taking a dimension of social conditions of human beings that has taken on an importance that has been identified by the United Nations Development Agency as being at the emergency stage of inaccessibility. We need to do something about it, raise it to the level of a human rights norm and call it the right to sanitation. We've still got some time. I can give you some more examples. So isn't that an interesting one? So you've seen that the right to water and sanitation is very directly related to the right to health, but because it went through the process of being analyzed and agreed upon by the General Assembly of the United Nations as being a human right, it has now acquired the status. But consider for a minute, stop and think. Yes, the General Assembly has called it a human right. The unanimity of the governments of the world have said this is a human right. But is it the same status as Article 12 of the International Covenant on Economic, Social, and Cultural Rights? That's a binding treaty. This is a resolution of the General Assembly, which is a political document of significance. The Universal Declaration of Human Rights is no more than that. It's a resolution of the General Assembly of the United Nations. So, at what point do we say, because it was adopted by the General Assembly, it is a right now? That's the easy one, because you can say it complies with all 5 conditions that the General Assembly set out on new human rights and has been adopted. So there have been other candidates to do the same thing. We certainly now know that in the framework of the right to health, there is also a right alongside of it, part of it, but also alongside of it, called the right to water and sanitation. Another issue that has emerged in relation to efforts to promote a right to an abortion and to promote reproductive and sexual rights has been the right to self-motherhood. And this study on advancing safe self-motherhood through human rights emphasizes that implementation of human rights relevant to the reduction of unsafe motherhood and enable women to go through pregnancy and safe childbirth. Okay, so this is something that has been identified as extremely important to the health of women. And so important that it has been defined by some people as a right to self-motherhood. Excuse me, a right to safe motherhood. But is it the same as the right to water? It has risen and been identified as a human right, but what it really means and what the text really says is that no, we don't really call this a freestanding right like the right to water and sanitation. We call this an instrumental right. This is an important component of the right to health. If you did not give enough importance to safe motherhood in the right to health, you must do so now. That's what we're trying to do by raising that issue. Same thing is true with tobacco control. Now, this raises another complex issue. You can see from this poster here that there are people who consider that the human right involved with tobacco is the right to smoke, smokers' rights. And in fact, when I moved from my full-time human rights work and international law work to my full-time public health work, I found myself in a meeting of public health ethics and so on, and I was under accusation. Oh, you're human rights? You're that professor of health and human rights? You're part of the problem. It's because of you that we have the problem of smoking and of guns. Because your human rights people tell people they have a right to smoke and they have a right to guns. You're a public health hazard. So, think about that for a while. How do you answer that question? And that's actually worth perhaps stopping on. Is human rights a danger to public health because of the right to smoke and the right to have guns? Maybe somebody from the back, because I can't. Somebody from the back want to say, do you think smoking is a human right? Do you think individual carrying of guns is a human right? Yes, could you, who can... Yes, could you, the fellow with the blue, all right, yes, blue shirt, light blue shirt. So, right to smoke, is it a human right? But she's saying smokers' rights. Why not? Oh, so it is. So we've convinced him. So, human rights people are a danger to public health because we value the right to smoke. Pass him a cigarette, would you please? Okay. So the need emerged to clarify to the public health people, say, come on, understand what we're talking about. The only human right at stake here is the right to health. and consumption of tobacco products is the cause of 8 million preventable deaths per year. There is no public health issue that is as dramatic as the 8 million preventable deaths from consumption of tobacco products. So the only human rights approach to this is to implement the right to health, which calls for the effective efforts at tobacco control, including through, and I have a much longer presentation on this, but including through the, I have to ask you first. Is tobacco control a subject of any international documents or treaties or anything? Somebody knows? I thought I heard a voice. Could somebody speak up? Is there anything internationally relating to tobacco control, or is it all the tobacco industry? TI decides. Tobacco industry. TI decides? No public health, World Health Organization. You go into the World Health Organization, you light up your cigarette and get to work. Nobody has any idea? Have you ever heard? Yes. Oh, I thought you were raising. She was just about to talk. She was going to say, I'm repeating your words, the Framework Convention on Tobacco Control. Oh, yes, that's what you're talking about. So she's drawing your attention to the Framework Convention on Tobacco Control, the only treaty adopted by the World Health Organization. The Framework Convention on Tobacco Control provides legal obligations, a treaty, the only one the WHO has, that requires states parties to take various measures to limit the production, distribution, marketing of tobacco products. It's an extremely important treaty that begins, like the Constitution of the World Health Organization, by referring to the right to health as a human right. The right to health in the Constitution of the World Health Organization, the right to health in Article 12 of the ICSCR, and the right to health in the Convention on the Rights of the Child. So that's a document that is building upon a human rights approach to health that is on tobacco control. And at the 17th World Conference on Tobacco or Health in 2018, we submitted and they adopted the Cape Town Declaration on Human Rights in a Tobacco-Free World. So there have been articles on the emerging right to tobacco control that a student of mine and I, who's a thoracic surgeon, published, and followed up by some other leaders in the health and human rights field, conceptualizing human rights to change tobacco, to challenge tobacco, and so on. Various movements that have given a human rights approach to tobacco control. Now we can conceptualize the drafters of the Universal Declaration of Human Rights sitting around a table in New York, where they did it, and puffing away on their cigarettes. Who would have thought that consumption of tobacco products is a threat to human rights? Evolution, Framework Convention on Tobacco Control, the awareness of the magnitude of the problem from a health point of view. If the problem is so big, it is inconceivable to implement the right to health without adequate attention to tobacco control. Hence the Cape Town Declaration on Human Rights in a Tobacco-Free World. Yes, this is what I was alluding to. So the WHO Framework Convention on Tobacco Control refers in its preamble to Article 12 of the ICSCR, the preamble of the Constitution of the World Health Organization, and the Convention on the Rights of the Child, as I was mentioning. So those are the references in the Framework Convention on Tobacco Control to those human rights mechanisms. And I became involved with the organization called ASH, Action on Smoking and Health, as a result of drafting this article. I guess I'm trying to avoid it for the purpose of time, but I can't resist. I want to share with you the story of Carolyn Dressler. So Carolyn Dressler was a student at the Harvard School of Public Health. She was a student at the Harvard Kennedy School in her mid-career. She's a surgeon, a thoracic surgeon. And she took my class on health and human rights. And after the first day of class, she came up to me and said, I was listing the topics that we're going to discuss. You know, we're going to discuss lots of issues of public health that have human rights implications. She came up to me and said, why isn't tobacco control on there? I said, well, you know, we're dealing with human rights issues. That's something that you medical people deal with. No. Tobacco, I have opened up so many lungs and I've seen what's going on in there. This has to be a human rights issue. I said, well, okay, it's important for you as a health person. Go ahead. Do your surgery and so on. You're doing the right thing. We do our human rights things. We try to protect human rights. So come on, forget it. Come up with some other idea. No, this has to be human rights. I couldn't stop her. So I said, okay, then why don't you do your paper for this course on tobacco control and human rights? Okay, I'll do it. And she went to work on it, and I helped her with it, and we worked together, and I began to see the ways in which an interpretation, a reasonable interpretation of the right to health includes tobacco control, how it's emerged in certain countries that tobacco control has been treated as a human rights issue, that people need to be protected from the harms of tobacco and so on. And as a result of her paper, we published this article and created an NGO called HRTCN, the Human Rights and Tobacco Control Network, that influenced ASH, an NGO that works on tobacco control, that has integrated tobacco control into its work, and we have mobilized people to submit to the UN comments on national reports under the ICSCR on the right to health, and told the committee, on tobacco control of the country reports, and if a country report says nothing about tobacco control, we urge the committee to remind that government of its obligations under the Framework Convention on Tobacco Control and of the necessity to integrate tobacco control into its health policies. Otherwise, it is not meeting the minimum obligations of Article 12 of the ICSCR. And guess what? It worked. This has become part of the regular reporting under Article 12 of the ICSCR. It's become widely accepted that tobacco control is integral, maybe not a freestanding human right, but here in the European context, we also managed to move the European European Network on Smoking and Tobacco Prevention to adopt the Cape Town Declaration and so on in the European context. So we've moved, so that declaration was particularly significant because it says, we agree that the manufacture, marketing, and sale of tobacco are incompatible with human rights, in particular the right to health, the rights of children and women, the right to development, the right to a healthy environment. We support the position in General Comment 14 that does refer to smoking and so on. So here is a way in which a public health priority has kind of pushed its way into the human rights framework and become a widely recognized essential element of the right to health. Unlike the right to water, it's not freestanding. There's no separate General Assembly resolution saying the right to be protected from tobacco products is a human right for all. No, but tobacco control is widely regarded now, where it was not before, as an integral component of the right to health. That's what we call normative expansion. Similarly, the right to essential medicines has been called a derivative human right. And the Human Rights Council, now this is relating to HIV/AIDS and COVID-19, and updated to COVID-19, but back when access to antiretroviral therapy was a major problem, and as you saw from the quotation from Jonathan Mann, acknowledged by those working on AIDS in the medical field as being of priority importance from a human rights perspective. The Human Rights Council adopted a resolution in 2009 on saying that access to medicines is one of the fundamental elements of achieving progressively the full realization of the right to health. And others have published on the human rights interpretation of the right to access to medicines. Again, here essentially when people say there is a right to access to medicines, usually at this time in the context of antiretroviral therapy for HIV/AIDS, what they mean technically, legally, for the lawyers in the room, is this is an essential component of the right to health. You cannot consider that the right to health is adequately implemented unless access to medicines is guaranteed. It does not mean freestanding right like the right to water. So that's a subtle thing. As an advocacy tool, we say the right to access to medicines, because that's an advocacy tool. Interpreting what we really mean by that is, well,
Sir, who will
yes.
take the responsibility for access to medicine? Is it government?
So access to medicines, it's an issue that has been addressed by the World Trade Organization in the Doha Declaration that this is based on, in which the World Trade Organization has acknowledged in the Doha Declaration that each state can determine if there's a public health emergency requiring it to take advantage of what's called the facilities of the TRIPS agreement, that deals with intellectual property. And essentially what this means is that if a government considers that there's an epidemic that is an emergency situation, it is no longer bound by the pricing of the pharmaceutical companies. The protection of the intellectual property rights of the pharmaceutical companies has to be set aside in the interests of responding to this public health emergency. Now, this is currently under debate in the World Health Assembly that is trying to adapt and adopt a new convention on pandemic preparedness and response that also includes a revision of the international health regulations. But the main pandemic treaty, it's called, the pandemic treaty seeks to address this as one of the primary issues that it's dealing with, to get agreement that the Doha Declaration needs to be updated, drawing on the lessons of COVID-19, and to get governments to agree that intellectual property rights should not be used in a way that prevent people from having access to affordable vaccines and other medicines needed to deal with pandemics. So it's a very important question. It's a very rich question. This whole idea of balancing intellectual property rights with the right to health has been under extreme pressure. Governments supporting industry in the World Trade Organization pushed very hard to say intellectual property rights. They own the intellectual property rights. They can charge the prices they want for the medicines. And the human rights say no. it must be, in time of need, of urgent need from a public health point of view, the human right to health must override intellectual property rights. This is still being fought. The current draft of the pandemic treaty that seeks to address the question that you just mentioned is being considered this week at the World Health Organization. So thank you so much for raising that. Similar reflection on essential surgery. Here, a group of surgeons reflected on this issue, and they said, yeah, also if essential medicines is part of it, there's a category of surgery that is not the expensive surgery, the elective surgery and so on, but certain things that are essential to save people's lives. A government can't say, oh, sorry, we don't have enough hospitals, we can't do it. No, you have to do it. So that's what is meant by essential surgery is integral to the right to health. Normative expansion, not a new right, not like the right to water, but you can no longer say, oh, well, surgery, that's not our problem, we're dealing with the right to health as a human rights issue. No, it's part of it. It's integral to, it's essential, it's integral to the right to health. And so now to summarize, and I think I can conclude with this, we started with Article 25 of the Universal Declaration of Human Rights. We expanded to the Covenant Treaty. The Covenant Treaty with its illustrative steps that included infant mortality, environment, and etc. Then it added the elements of the right to health. Then General Comment 14, which defined the core minimum. And General Comment 14 also listed a set of obligations of comparable priority. This is what we went over earlier, right? But I'm giving you greater detail on it. Then we have Malhotra's attributes, in which he listed certain things. That's not an official treaty. That's simply a document of the Office of the High Commissioner for Human Rights. But it adds to the understanding of the normative content of the rights. Then we move on to derivative rights that come out from various academic publications and meetings and conferences and so on, where in the case of essential and emergency surgery and essential medicines and tobacco control, these have all been proposed. So one of the human rights scholars has written on relative normativity. We know that the treaties containing the right to health are what we talked about in the first part of this talk, culminating with Article 12 of the ICSCR and the regional treaties and the UN treaties. Those are treaty norms. But these interpretations that I've been giving you are non-binding. And a prominent international lawyer has said non-binding instruments have an essential and growing role in international relations and the development of international law. So the general comments that we read about and the other documents that we've seen are not just wishful thinking. From this understanding of relative normativity, they do add to the content of the right. That's what we mean by normative expansion. It's not going from a hard law right to soft law to wishful thinking. No, the soft law is also, such as the resolutions relating to the right to water and sanitation and all of the documents relating to tobacco control and essential medicines and essential surgery, all have a significance, as she says, in the development of international law. They are important. They are reference points that we can use. So I think the final point that I was going to raise, but I think I've run out of time now. It's already 1 o'clock. Time is up. The final point that I'm going to simply draw your attention to by showing you the outline is that these rights, once established in a treaty, are useless unless and until we use a mechanism of enforcement that we call in international relations implementation. And implementation is carried out through promotion and protection. So, right to health, how do we implement it? We develop awareness, we elaborate further standards, we build up institutions, and then 4 means of protection. We monitor compliance with reporting procedures, complaints procedures, adjudication through courts that make decisions, and we saw the Indian Supreme Court and so on. The Human Rights Council provides political supervision where resolutions are adopted and government's reports are examined. Humanitarian action where organizations provide resources. So we're out of time. I guess I'll skip the conclusion. But the conclusion is simply to say we've come a long way. We've come from a few small words in a document that didn't even mention right to health as such, to the right to health defined, to the right to health expanded, to essential rights being added to the right to health, and to all of these mechanisms of promotion and protection being used to translate these rights on paper into rights in action. And that's why the right to health has gone a long way since the Universal Declaration of Human Rights. Thank you very much for your time. I hope this has been useful.